Welcome everybody. Today we will be talking about adolescent idiopathic scoliosis. We will be discussing the natural history, evaluation, and Lenke classification of adolescent idiopathic scoliosis. Adolescent idiopathic scoliosis presents between 10 to 18 years of age and is the most common type of idiopathic scoliosis. It is usually a three-dimensional deformity. The three dimensions are lateral curvature, vertebral rotation, and sagittal deformity, which is mostly a hypokyphotic or lordotic deformity. The rib hump due to vertebral rotation gives the appearance of a hyperkyphosis, but in reality, most of these deformities are hypokyphotic. The etiology of adolescent idiopathic scoliosis is largely unknown, and the respiratory involvement is much less compared to that in infantile idiopathic scoliosis and juvenile idiopathic scoliosis. When present, respiratory impairment is only seen in thoracic curve and is related to the severity of the curve. Coming to the natural history of adolescent idiopathic scoliosis. The factors that are related to the progression of AIS are it progresses more in girls compared to boys. Premenarchal girls have a higher risk of progression. The factor that relates most closely with the progression of AIS is the period of rapid adolescent growth or peak height velocity. It is during this period that the curve most severely deteriorates. So if the child is presenting before this peak height velocity, then the progression chances are higher, and if the child presents after this, the chances of progression are lower. Risser sign 0 and an open triradiate cartilage have higher chances of progression. Double curves have higher chances of progression than single curves. Thoracic curves have higher chances of progression than lumbar curves. More severe curves have higher chances of progression, and a vertebral rotation of grade 3 or more has higher chances of progression. Now coming to the clinical evaluation of adolescent idiopathic scoliosis. In history, we have to ask history about onset and progression, any history of back pain which warrants a further investigation like MRI. Any history suggestive of neurologic weakness again warrants a further investigation using MRI scan. Menarchal status is asked to ascertain the progression. Parental height gives us an idea whether the child has achieved her growth or not. A family history of scoliosis is important because in case of a positive family history, especially a sibling, the chances of progression in these cases is higher. And a surgical history, especially a prior thoracotomy, can give us an idea about any congenital heart disease that was treated earlier. In examination, we have to do a height and serial height measurement, which may give us an idea about the peak height velocity. The skin of the back has to be carefully examined for any dimples or hair patches or cafe au lait spots, which may give us an idea about any underlying neuraxial abnormality. We also try to ascertain the balance of the spine. We look for any asymmetry of the shoulder, scapula, ribs, or waistline. For a coronal spinal balance, we drop a plumb line from the base of the skull or the spinous process of C7 and look at its relationship with the gluteal crease. Normally, this plumb line should not deviate more than 1 to 2 cm from the gluteal crease. Any more deviation is an indication that there is a spinal imbalance in the coronal plane. We look for any thoracic kyphosis. To differentiate between a functional and structural scoliosis, we do the Adams forward bending test. The patient is asked to bend forward. A true scoliosis or a structural scoliosis, due to the vertebral rotation, becomes more prominent, whereas a functional scoliosis disappears on forward bending. A scoliometer may be used to assess this truncal rotation, and a truncal rotation of less than 7 degrees normal. Any limb length discrepancy has to be measured, as this may be a cause for functional scoliosis. A thorough neurological examination has to be performed with special attention to the superficial abdominal reflex, as this may be the only abnormal neurologic sign in these patients. Coming to radiographic evaluation, we get plain radiographs of the whole spine in standing, PA and lateral view. This helps us to gauge the magnitude of the deformity and the spinal balance in coronal and sagittal plane. We also get supine lateral bending films to assess the flexibility of the curves on the convex side bending films. Some additional optional films are traction films, Fulcrum bending films, and push prone radiographs to assess flexibility of the curve. The assessment of skeletal maturity is done through Risser's grading, triradiate cartilage open or close, olecranon apophysis ossification, and digital ossification. In Risser's grade, it is the calcification of the iliac wing apophysis. So this is the iliac wing apophysis, and the iliac wing is divided into 4 parts. The calcification is graded. If there is no calcification, this is Risser's grade 0. If one part is calcified, this is 1, 2 parts is 2, 3 parts is 3, and 4 parts is 4. When this entire calcified apophysis is fused with the iliac wing, this is Risser's grade 5. Risser's grade 0, as we have seen, has a high chances of progression. MRI in adolescent idiopathic scoliosis is indicated in case of left-sided curves, significant pain, a rapidly progressive curve, hyperkyphosis, or when operative treatment is planned. Coming to the vertebral rotation grading, it is done through the Nash and Moe grading system. It is graded as grade 0 when the pedicles are symmetrical and equidistant from the center. For further grading, the half of the vertebral body is divided into 3 parts. In grade 1, the pedicle is still within the first segment but is slightly asymmetrical, and this pedicle, that is the concave pedicle, has started disappearing. In grade 2, the convex pedicle has come into the second segment and the concave pedicle has almost disappeared. In grade 3, the convex pedicle has come into segment 3 or the third segment, and the concave pedicle has completely disappeared. And in grade 4, the convex pedicle has crossed the midline. Now coming to the Lenke classification of adolescent idiopathic scoliosis. The Lenke classification is divided into 3 parts. The first is curve type, the second is lumbar spine modifier, and the third is thoracic sagittal modifier. In curve type, we have 6 types, which are main thoracic, double major, triple major, thoracolumbar lumbar, thoracolumbar lumbar, structural main thoracic. Now, this may sound very complicated, but is actually quite easy. So the first type you have to remember is main thoracic. Then you retain the thoracic and a double comes, so it becomes double thoracic. Then you retain the double and a major comes, it becomes double major. Then you retain the major and it becomes triple major. The fifth type you have to remember is thoracolumbar lumbar, and then you add a structural main thoracic to it for the sixth type. For lumbar modifier, we draw the central sacral vertical line. So it is a vertical line on PA view or AP view from the center of the sacrum. Now we look at the relationship of this line with the lumbar apical vertebra. So we look at the lumbar curve because it is a lumbar modifier. We find the apical vertebra and we look at the relationship of the CSVL with the lumbar apical vertebra. Now, if the CSVL is between the pedicle of this apical vertebra, it is type A. If it touches the apical body pedicle, it is type B. And if it is completely medial to the apical body, it is type 3 or C. The last is the thoracic sagittal modifier, for which we see the angle between T5 to T12 on the lateral view. And if this angle is less than 10 degree, it is hypokyphotic or minus. If it is 10 to 40 degree, it is normal. And if it's hyperkyphotic or greater than 40 degree, it is plus. So hypo is also designated as minus and hyper is designated as plus and normal is designated as N. Now, to describe the curve completely according to the Lenke classification, we describe it as curve type 1 to 6 plus lumbar spine modifier plus thoracic sagittal modifier. So for example, if it is a main thoracic curve with a A-type lumbar modifier and a hypokyphosis, we will describe it as 1A minus. Now to understand the curve types, we have to understand some definitions. What are these? First is major curve. Major curve is the largest curve by Cobb method and it is always structural. The location of the apex dictates the location of the curve. So a thoracic curve is when the apex is between T2 to T11 to 12 disc. It is further divided into proximal thoracic if the apex is between T3 to T5 and below to T11 T12 disc is main thoracic. Thoracolumbar is T12 to L1 and lumbar is from L1 L2 disc to L4. For minor curves, the structural criteria we have to know. These are for proximal thoracic, main thoracic and thoracolumbar lumbar, a side bending corpse of greater than 25 degree on the coronal plane. And on the sagittal plane, a T2 to T5 corpse of greater than 20 or a T10 to L2 corpse of greater than 20 for main thoracic and thoracolumbar curves. Coming to the curve types. So, what is a main thoracic curve? So, for this table, again, it is quite simple. For the first 4 types, the main thoracic will be structural, and for type 5 and 6, the thoracolumbar lumbar will be structural. Now, depending on the name, we will define the non-structural or the minor structural curve. So, we have seen the major curves and the major curves for 5 and 6. So, for main thoracic, only the main thoracic curve will be structural. For double thoracic, the proximal thoracic, because there are 2 structural thoracic curves, so proximal thoracic will also become structural. For double major, the main thoracic and the thoracolumbar will become structural. For triple major, all 3 will be structural. For thoracolumbar lumbar, only the thoracolumbar lumbar will be major. And for thoracolumbar lumbar structural main thoracic, the main thoracic and the thoracolumbar lumbar will be major. Coming to the lumbar spine modifier, so we draw the CSVL and we look at its relationship between the CSVL and the apex of the lumbar curve. So we have to remember, we have to see the apex of the lumbar curve, not the thoracic curve. So if this is the apex of the lumbar curve, if this line is passing between the pedicles, it is type A. Now, if it is touching the pedicle, it is type B. And if it is completely medial, it is type C. So friends, this was a discussion on the natural history, the Lenke classification, and the evaluation of adolescent idiopathic scoliosis. If you like these videos, please hit the like button and subscribe to the channel for further videos. Also, comment in the comment section regarding the topics you will like to be covered in the future videos. Thank you.